A Healthy World provided by Turkish Journal. We are at the United Nations today with a very special guest, Dr. Sine Akten. How are you today?
Thank you, Nishat.
Let's hear from her about Goal 3, which is Sustainable Development Goal for Health and Wellness. We want to know about health disparity and how is Goal 3 is being achieved and what is the hope for the next decade. How are you today?
Thank you, Nishat, for having me. It's a privilege to me to have you here as a guest.
Thank you for being with us today. Tell us about your background and health disparity itself.
Okay. My name is Sine Akten, as you actually said. I am working in United States in New York as a kidney specialist over 10 years. I am mostly medicine, but more specialized on the kidney diseases. I worked in Turkey, Istanbul and Izmir for 5 years as a kidney specialist. I moved here in 1998 and I actually established my business and my career here is 2006 to start. As far as you actually mentioned that the comparison between the countries, I'm lucky to have these both experiences in this country and then in my hometown country. Yes, I am observing since my actual medical career. However, since you are in the medicine and in advance, like in a subspecialty such as the kidney disease, we were observing a lot of changes over the decade in terms of health disparities.
What are the key factors in Turkey and compared to USA?
Yes, in general, I think that we could put maybe health disparities and divided 3 subjects. One, communicable factors, and which is we called infectious factors to affect. The second one is non-communicable and non-infectious factors, and third one is environmental factors. Environmental and exposed factors are we call preventable, and the communicable the factors may not be preventable. I will go detail, but non-communicable factors is mostly preventable if you are detect earlier. What I'm saying is if you are, I'm talking about kidney disease, which is I'm going to reflect a health disparities to just talk with the kidney disease. Kidney diseases are depending on the other disease most of the time. Diabetes, hypertension, and the infectious and kidney itself disease are composed as a kidney disease. Most of the time we have seen the patients majority in worldwide diabetic and high blood pressure. This is what we're calling non-communicable factors.
Are these people with the socioeconomic status they are poor or how?
So Nisha, you got really point. That's why I was saying the communicable or non-communicable or exposure or environmental. These are the all components depends on the social economic status. 60% of patients for each group have actually so low social economical status or incomes or middle we could call. So in Asia it's 68%, in Middle East close 70%, and in New York, United States is 60% of patients who have kidney disease. When you look at the background, they have a low social economical status. There in locally you should see the different parameters and different actually a scale is really affecting that part. In Turkey, in a health disparity is affected by the social economical status mostly, and also unfortunately environmental factors that you could prevent in a more deep and large scale of development.
What do you mean by environmental factor? What are some of the examples?
For example, there is a new entity that we are dealing with right now. It's arising from the Central America. We call Mesoamerican nephropathies. The nephropathy, which we call kidney disease, which is mostly seen in the farm, with the patients who is actually working as a worker in the farm, long hours, and with exposure with the agricultural toxins or agricultural pesticides or insects. So that's why we were always saying that the environment factors depends on also like air pollution, water pollution. These could be prevented by a little bit more global approach. So this cannot change. If you cannot change the all factors in baseline, you could not change the progress. So for that reason, in Turkey we have more seeing the patient who are already exposed that kind of a low privilege areas with a water pollution or either or air pollution. These are affecting air. I mean, when you compare it to here, I'm always comparing at the same time. We have a more communicable factors, which we were saying that the patients are here, low income, uninsured, underinsured. These are actually coming here. That is affecting their other disease, which is diabetes, the communicable part of the health disparity. So when you look at here, we have also another cultural differences or ethnicity differences and race differences. The black population are mostly that are actually population here, 60-70, close 70% of patients who have a kidney disease. When you look at that race-oriented or ethnicity oriented, we have more black peoples. It was documented in 1980s in Alabama, which is the one the beautiful articles been written by the George Hubinson, which tells us that why the black people have kidney disease compared to equivalent, the age of white males or females. They look for it and then they found again a low social economical status.
Also, does it have to be when they are coming to the doctor, if they're coming to the last stage?
Yes, that's correct.
And because they might not have a health insurance, is it affecting?
That's correct. So health insurance in this country is a problem.
Yes.
Which is affecting the access to health services. In Brooklyn, we have a very and growing, unfortunately painful problem for insurance in the status of immigrant and plus minus that they're the uninsured even though they are not immigrant.
Mm-hmm.
So it's affecting the renal access, it's affecting the kidney disease services. We've been seeing, as you already mentioned, that late stage of kidney disease, which requires in 2-3 years as a kidney dialysis, we call sort of renal replacement therapies. That's so sad to see every time in my actual practice, the patients coming from stage 4 and 5.
Yes.
You're right that this is unfortunately that also increased budget in the health economy here. So we have unfortunately is increasing the expenditure of all health economic parameters because of these uninsured patients whom actually having more and more progress and complicated diseases is also a burden for the cost of analysis.
Wow. And since we are talking about the Sustainable Development Goal 3, which is health and wellness, for the last decade, what have changed, improved, and what are you looking forward to because it's called Agenda 2030, so we are, we are reaching to 2030 in case of reaching the goals. So what is your take in it?
In past a decade, I believe, and I'm actually reviewing the literature, the education and the awareness are the most propelling progress in health in general. In kidney disease, we have also awareness as my main initiative point increased past 10 years. There is a lots of supportive organizations and patient collaborated studies, and unfortunately recently been understand the main core issue is the save the individual being remembered, save the individual patient is going to save a family save other families, and then this is always goes from the a patient self or patient centered the healthcare. That's the reform. I believe that recently the the global look or community look, it just comes back like to square one, to patient-centered, patient-oriented. For that reason, that the education is changing, and awareness is changing, and changing the way of out of box way. I think that's the question that you two questions. In the first part, education and awareness change, and detection of disease is change.
The detection, yeah.
Exactly, has been changing to the simple tools.
That's amazing.
That's amazing. So you could figure out in the bedside that the patient has, or it's going to have worse kidney disease, just one small strip. We called the urine strip. I don't want to go details, but this is very simple tools and really make the difference in long term. Okay, so for that reason, the consensus on the disease are really change, and the social media, as was talking about it, it's been evaluating to the point that the one patient affect the other patient, the patient affect the others and the communities. Okay.
You mean sharing the knowledge and the simplicity of the tool to detect disease that has been improved, right?
And the cost of this, unfortunately, having simple tools, having simple tools, which is development, is costly. However, in the end, the simplicity of the tools is changing the economic burden to less than. So for that reason, I believe that the past 10 years, the entire researchers tried to find out the one simple tools to create really the impactful results. Even the cancer studies goes a gene oriented, a one simple tools, which is it's not simple for evaluate, but it's still goes in the one targeted area. Every the lines, every I believe medicine parts right now is going to find out the one simple tools to just address the really impactful outcomes. In kidney disease, we were also I told you we changed that detection of the disease, early referrals point. And the future is
the next decade. What are you looking for?
Yes, when we were getting early referrals, early detection, we can change the disease fate, the fate of the patient, fate of the disease, nature of the disease are changing based on early detection, right? Early diagnosis. So based on that, the statement that you should also reach that person who already showing the sign of weakness or showing the sign of disease, right? So to reach that, as I told you, we have all disparities still there. It's so hard to resolve, however is resolving. But to get there, to find the target population, you should have two tools. Access them with emailing, electronically access. That new technology just going to digital health.
Yes.
Especially in developing and developed countries, they are actually more going to digital health. Digital health is just the health that we were discussing all the time past good 10 years, I believe, but since 2015 we were start discussing about can we apply the electronic consult onto a practical life. Especially in kidney disease, I am the expert on the electronic consulting. Means that you cannot see the patient maybe on time physically, but you can aware there is a patient out there need your help. So that's the new way of applying medicine in actual in future.
That sounds very promising. And thank you for giving us such a great insight on the health and wellness in terms of kidney disease and also achieving the Sustainable Development Goal 3. Thank you so much, Dr. Akten, and thank you for joining us today. You are watching A Healthy World. I'm Nishat Mirza from Turkish Journal.